Why can't the eye fix itself? Every other tissue in your body tries. Skin closes over a cut. Bone knits back together after a fracture. Even the liver, which most people think of as a chemical factory, can regrow more than half of itself after surgical removal. But scratch the cornea, the clear dome at the front of your eye, and if the damage is deep enough, it stays. Scar tissue fills the gap. The scar is opaque. You go blind in that patch, and it does not reverse. The standard answer you will hear is that the cornea is a delicate avascular structure, meaning it has no blood vessels and repair is complicated. Seal a petri dish of corneal cells, deprive them of nutrients, and watch what happens. They do not regenerate the way skin cells do. They stall. So it is not that the eye is fragile, it is that the cornea lacks the repair machinery the rest of the body relies on. That answer is satisfying for about 30 seconds until you ask the next question. And then that question breaks something and you need another answer, and by the time we are done, you will be somewhere you almost certainly did not expect to arrive when we started talking about eye drops. If the cornea lacks repair machinery, where does the machinery normally come from? The answer is a narrow ring of tissue at the very edge of the cornea, where it meets the white of the eye. That ring is called the limbus. Inside the limbus lives a small specialized population of stem cells, limbal stem cells, and their job is exactly what it sounds like. They divide, produce new epithelial cells, and those cells migrate inward across the corneal surface like a slow tide, maintaining the clarity that lets light pass through cleanly to the retina behind it. The cornea you are using to read this sentence was largely built by those cells replacing themselves over the past few months. The mechanism is constant and invisible, and it works until it does not. The failure mode has a name: limbal stem cell deficiency. It happens when the limbus is damaged by chemical burns, by Stevens-Johnson syndrome, by certain autoimmune conditions, or simply by the overuse of contact lenses across years. When the stem cell reservoir is depleted, the cornea cannot replace its surface. Conjunctival tissue, the pink tissue meant for the inside of the eyelid, starts migrating onto the cornea instead. Blood vessels follow. The surface becomes opaque and irregular. Vision drops, sometimes to near zero, and no amount of glasses or standard corneal transplants can fix it, because the transplant will fail too, for the same reason the original tissue failed. The machinery is missing. So the logical question becomes, can you put the machinery back? For about 20 years, surgeons have been trying. The standard approach involves taking a small biopsy from the healthy limbus of the patient's other eye, or from a donor, culturing the cells in a laboratory until there are enough of them, and then transplanting the resulting sheet of tissue onto the damaged eye in a surgical procedure. It works. Studies tracking patients over several years show meaningful visual recovery in roughly 60 to 80% of cases with autologous transplants, meaning tissue taken from the patient's own healthy eye. The cells reestablish the limbal niche, the conjunctival invasion retreats, the corneal surface clears. But here is the problem surgery always carries. You need a surgeon. You need an operating room. You need the patient to be fit enough for anesthesia. You need equipment for cell culture that costs money most clinics in low-income countries do not have. Corneal blindness from limbal stem cell deficiency is not evenly distributed across the world. Burns from cooking fires, acid attacks, trachoma infections left untreated. These happen disproportionately in exactly the places where a stem cell transplant theater is not available. The treatment exists. The infrastructure to deliver it does not. This is the rung where the question goes sideways, because the problem stops being about eyes and starts being about drug delivery. The researchers working on stem cell eye drops were not, at their core, asking a question about ophthalmology. They were asking a question that pharmaceutical engineers ask about every therapy. What is the simplest possible vehicle that can get an active agent to the place it needs to go? A topical drop is the simplest vehicle imaginable for the eye. No surgery, no theater, a bottle, a dropper, a patient who tilts their head back. The question was whether stem cells could survive in a formulation stable enough to be stored, dispensed, and absorbed by a damaged corneal surface. The short answer, based on early work published by research groups in Italy and Australia, is that they can, conditionally. The cells must be suspended in a matrix that protects them during storage, a hydrogel or a similar carrier, and that matrix must dissolve or become permeable on contact with the tear film. The concentration matters. The studies used roughly 500,000 cells per milliliter of solution, a density high enough to seed the limbal niche after repeated application, but low enough that the drop remains fluid. In animal models with induced limbal stem cell deficiency, repeated dosing over 2 to 4 weeks produced measurable reepithelialization of the corneal surface. The cells were not just surviving the trip, some of them were integrating. Which raises the hardest question on this ladder. Are these cells actually becoming limbal stem cells once they arrive, or are they doing something else? The distinction matters enormously. A cell that integrates and replenishes the stem cell niche is a permanent repair. A cell that temporarily patches the surface and then dies has bought time, but not a cure. The evidence here is preliminary and honestly incomplete. Researchers have used marker proteins, particularly p63-alpha, a transcription factor expressed at high levels in genuine limbal stem cells, to identify whether transplanted cells are maintaining the right identity after integration. Some studies report positive p63-alpha staining in cells at the limbal margin weeks after drop application. That is a meaningful signal. It is not proof of long-term niche repopulation, and no human trial has yet run long enough to say with confidence that the repair is durable across years rather than months. Step back for a moment and notice the distance we have covered. We started with the embarrassingly simple question of why the eye cannot fix itself, and the answer was that a small ring of stem cells does the fixing, quietly, every day. The answer to that produced the failure mode when those cells are gone. The failure mode produced the surgical fix. The surgical fix produced the access problem. The access problem produced the idea of a drop. And the drop produced the deepest question of all, which is whether transplanted cells can truly rebuild a niche rather than just occupy it temporarily. The honest top of this ladder looks like this. Stem cells in a drop can reach the cornea, survive, and produce early markers of integration. What remains genuinely open is whether they repopulate the niche durably, what the optimal carrier and dosing schedule look like across different injury types, and whether the first human trials will replicate the animal data or expose failure modes the models missed. The cells arrived. Whether they stayed in any permanent sense is still being measured. If you have a question that belongs on the next rung, leave it in the comments. The ladder keeps going.